I'm going to go ahead and do that now. Okay, go ahead. So you could just,
Great.
you wouldn't mind.
Sure. Yeah. So we've,
yeah,
starting, just a moment ago. Yeah. As we have started to ramp up our efforts with Rotaries and speak to a number of the Rotary clubs around the area, it's probably as far north as Boulder and maybe now getting into southern Weld and then down as far as, the south suburbs of Denver at least, and then having some presence at the large, the more regional or district level Rotary meetings where there were representatives from all over the state. One of the things we've been talking with clubs about is things like helping to promote safe disposal options for communities as one of those. Others have been things like awareness of naloxone, overdose reversing drug that we're trying to push much harder on now in terms of public awareness of what it is, why people need it, and how to get it. We'll have more programming coming out on that very, very shortly. We have an RFP out to work with a vendor to try to do that. But there's other things that it could be, things from working with Rotaries to then partner with school districts and get messaging into PTAs or into assemblies in schools and try to reach middle schoolers or high schoolers, very targeted audiences of those that might need some prevention messaging. So there's a variety of activities that are, obviously appropriate, just given the focus of wherever a specific Rotary club wants to move. One of those has, like I said, been safe disposal. At the state level, we've been promoting this for some time. There's a variety of reasons for it. The chief one being that the number one reason, vector into the problem, number one reason people end up in a situation that we consider less than ideal. So anything from dependence to addiction to overdose to reliance on a medication that may or may not be working for somebody to ultimately overdose or death, anything like that that's undesirable. The number one way people start non-medically using opioids or having problems is in the medicine cabinet. 70% of people who end up in a bad way started with somebody else's leftovers in their medicine cabinet. 17% of people started with their own leftovers. So it's, the largest vector in is leftover stuff in the medicine cabinet. So we know we have a problem with a lot of medications still going out, even as recently as last year, about 190 million prescriptions a year going out at retail, averaging 43 tablets a script. So we're still at 8.5, 9 billion tablets a year going out at retail. All that's, virtually all that sits in medicine cabinets, majority of it unused. So we know we have a major problem, and this is one of our focus areas. Because of that, we think it's among the lowest hanging fruit we have is to clean out medicine cabinets and send that messaging about safe storage. If you do, our 3 messages are safe use, don't share it, don't mix it, none of that. Safe storage, keep it out of the reach of somebody who may have access to it that you're not aware, which is essentially everybody. Your neighbors know, your kids know, your friends know, your electrician knows, everybody knows where the opioids are because there's 190 million prescriptions every year. And it's easy. Just go to the medicine cabinet, there's some opioids in there. Everybody knows this. You may not think so, but they do. And so we think the mess.
Do you have a percentage of the general population or households that would actually have opioids in the medicine cabinet? Is that ever been studied?
Yeah, our most recent survey data suggests that's in the 30 to 40% range of people that admit having leftover opioids in their medicine cabinet. That's a survey that we did, a statewide survey last fall. Yeah. And it's probably a higher number given social desirability biases. Most people now know that the opioid crisis is a crisis and that opioids are not good to have laying around, and people know that. And socially, it would be desirable to say, oh yeah, I got rid of mine. So we think the number is probably higher. The error, the direction of that error is probably higher than 35 or 40%. So I do sort of straw polls when I go out to, whether it's a Rotary or a PTA or wherever, and say, how many people, have opioids that of, have opioids in your medicine cabinet that you're not using. And it's, 3 out of 10, 4 out of 10. Yeah. So it's probably half, closer to half that really do have them left over. So we know if that's half of the medicine cabinets in the state, It's probably true across the country. Half of all medicine cabinets have some in them. It's a huge problem. And the
Right.
quantities of these are not just 1 or 2 left over. It's usually people got 30 or 40. They use 3 or 4, and they've got 36 tablets left over.
Right.
So it's enough to get somebody started. And then they go to other medicine cabinets, go to my neighbor, go to Aunt Sally's house, whatever it might be, and get a few more. And boy, this is great. And whether I'm trying to manage my own pain or recreate, either way, not under the direction of a doctor, it's all non-medical use, and it really often ends up in problems.
Right.
So we just think this is super high priority, is make people aware of, safe use, safe storage, and safe disposal as general messaging themes. But in the safe disposal vein is, get this stuff out of your medicine cabinet. You're not doing yourselves any favors by keeping the stuff around for a rainy day. Worried that you won't get more opioids. I tell people you should really be worried about the fact that you're probably going to get some more and you shouldn't have them. You're doing yourself. There's better alternatives. And we're working on teaching people about asking for alternatives. What are your options? Opioids might be a choice. They aren't the only choice.
Right.
And have those kinds of conversations with your doctor. And we're really starting to see prescribing drop, especially for the first prescription, acute pain. We're seeing drops in prescribing, which is good, but we still have a long way to go.
And I've heard from a couple of Rotary clubs where you spoke about that topic. They were very enthusiastic about having gotten that message. And I was actually wondering at some point if we could enlist you to maybe deliver that talk at our Rotary Club.
Absolutely. Yeah, we've got a variety of them, and I sort of have the general sort of, oh my gosh talk, right? That here, I didn't realize some of these things. And then, it spurs some activity, and that could be it has ranged from, we want to do naloxone and make people aware of that, or safe disposal, or we want to help with, now, especially what we're calling ALTO, alternatives to opioids. Everything we have to have an acronym in our world for some reason.
Right.
We just do.
Right.
But it's the ALTO acronym for alternatives to opioids. And it really is an emerging literature base for people to understand from the provider side, what can they do? And from the patient side, what are your choices? And people don't know that, simply taking Tylenol and ibuprofen in rotation is almost twice as strong as opioids are anyway. That people don't think, if you tell them just go to King Soopers and get some over-the-counter pain meds, that's going to be stronger than your opioid. People don't believe that.
Right.
When in fact, it's true.
Well, and if you add caffeine to that, you've got even a better cocktail that works.
Absolutely. No, there's very effective ways to treat most forms of pain. It doesn't treat everything, or if somebody's got renal disease or a clotting disorder or whatever. But if there's, probably 95 out of 100 people, that will work better for.
Right.
And if we can deal with 5 out of 100 that have contraindications and we need to give something else, that's fine. We'll be exposing a lot fewer people to something that is potentially addictive, and by definition, we're going to, with such less exposure, we'll have far less problems.
Yeah, and Jamie and the rest of some of the other team members you have in your fold have given us a good, I'm talking about our particular Rotary Club, a really solid grounding on the oh my gosh thing and the safe disposal piece. We haven't heard the what's the acronym again for the
ALTO? Yeah, ALTO, just like a
okay.
soprano, alto, tenor, bass, but it's ALTO, but it just happens to be alternatives to opioids.
Okay, or it could be stop opioids, right?
Could be, right, exactly. It's just we're trying to. It's good. I like it. If I'm Italian.
Yeah. All right. So sorry to interrupt, but if you would continue,
no.
It'd be great.
No, that's fine. And so so we're trying to push safe disposal, and the ways that we do that, there are periodically take-back events that the DEA has hosted for the last 7 or 8 years, and we're very big fans of those because a lot of people think about, spring cleaning, really good chance to go through my medicine cabinet, clean out whatever I'm not using, and get rid of it. So that's not a bad concept. And we're big supporters of it. And our DEA take-back events in Colorado have done extremely well over the last 7 or 8 years, taking back a lot of medication, more per capita than our 7 or 8 regional state counterparts in this DEA region. So we're proud of that. We think a lot of that has to do with the fact that we advertise the heck out of those and try to get people out to those take-back events. But long term, we think that even if somebody has, it's not good for someone to wait 6 months to get rid of something that's left over. And it's less suitable, we believe, to flush it or do that, even if the data, which I appreciate the studies you sent, because I've read those and seen those, that the effect to the environment is not as clear, that whether it's really a benefit or not to do that this way versus another. We still think, and what EPA recommends and DEA recommends, is take these and incinerate them at an EPA certified incinerator so that the environmental impact will be virtually nil. And we're sure of that it'll be virtually nil. There will be virtually no chance of just diversion that way. And even if there's not a certainty in terms of the water supply, the folks we've talked with that run municipal, water treatment facilities will tell us they have virtually no filtering for things like that and can't handle stuff. So anything that's in the water, they just say, look, the less in the water, the better. Even if they, can't quantify specific for this drug and that drug, how much effect it's having in plants and in vertebrates or fish or whatever, where the studies have been done. It's still, we believe the preferred route is dispose of those. FDA still on the label lists flushing as an option. DEA, virtually everybody in prescription drug abuse circles says we'd rather not people flush. We would rather them take back to the pharmacy or to a take back location and have those removed and collected and incinerated. So there's no possibility of diversion or potential issues with water filtration or the environment. So it's just the general, I think, consensus among most is that the desirable is to do take back, and it also builds behavior. The long range goal is just like recycling, right? We want people to take their paint back to the paint store. Don't want them taking the paint and throwing it away, going in a landfill. Same with electronics, all kinds of things.
I just want to interject there that I'm here from our Environmental Sustainability Committee, and we're very interested in not flushing the meds down the toilet.
Yep.
Well,
we totally agree. Even though FDA says so, and some people quote that and say the labeling in the FDA says go ahead and do this, and we disagree with the FDA. I have sat with the FDA commissioner and told him to change it. Change that, please. And what do you want me to do? And I was list 3 things for him: make naloxone over the counter, flip around the requirements about prescribing opioids, and take the flushing recommendation off the label.
Yes.
And that's the 3 things that I asked him to do. And so far I'm over 3, but we're working on at least getting 1 out of the 3, hopefully in the next few months, that he's working on the educational requirements.
Opioids, but toxins in our water supply kill just as effectively. It just takes a little longer.
Yep.
Yeah, Rob, I have to play the devil's advocate here, though. That if looking at the amount of behavior change that's required, and the fossil fuels, it's required to do take back effectively, with the presumption that at best you're only going to get a 50% response. That I'm wondering, that's what brought this up for me, as to whether this is, if evidence is forthcoming about the real impact on animals and fish and downstream effects of putting the flushing opiates into the toilet, if the dilution factor is such that there's really we don't have in other words, if we don't really have the evidence and the danger is there, what's the relative cost benefit, if you will, of going one direction versus the other. And it was that question that was being raised. That
Gary, my thing with that is, there's studies showing that these are toxic, is trying to show it. It's the same thing with a lot of things in the environment. When you try to show it in the environment, it becomes much more difficult. And then the companies say, well, the studies show this one way, but it's not environmental studies, and we need environmental studies. And then nothing is done. If you can show it in the lab, it's an indicator you got a problem. And the FDA is built on that assumption. with its system, and EPA is built on that assumption, at least until the Trump administration. And so we got to go with lab studies as best we can, because if we're talking about longitudinal studies in real terms, it's going to take generations to prove something.
So, Rob, I hope you don't mind us having this in the conversation. We haven't really had had an opportunity to do that ourselves yet, but you know, and I'm just being the devil's advocate here. So we'd love to have any evidence that's available that you can supply, or arguments for you know, for going one way or the other from our standpoint. Just to back up for a second, I just wanted to say again that the reason for having this discussion is to make sure that we don't undertake a major project and enlist a bunch of other Rotary clubs to do what we're doing, when it turns out in a couple of years that when the evidence is in that the policy changes. People are dying every day, as you pointed out, and if we can save lives by, you know, I think the recommendation is, if you can't get it to a safe disposal site, then flush it or trash it, right? Isn't that your recommendation now, Rob?
Yes. Oh, sorry about that. Was on mute again. Yes, I agree. Our strong preference and our messaging is take it to a safe disposal site if at all possible. We've been working very hard to ramp that up, so it's not far for people to do that virtually. And, you know, we're at 63 of 64 counties in Colorado have a safe, you know, permanent safe disposal location, so people can do that anytime. Not all of them are 24/7, but it's pretty close to it around the state, that anytime you want, you can take something back. So it's that barrier is dropping quickly, as far as there is nowhere for me to take this. You know, so it should be relatively easy for people to do. Most of them now are leaning towards being in pharmacies, and that's what our long range objective is, just like tires, paint, and such, that you take it back where you got it. And well, it makes the most sense for people behaviorally to, wherever I got the paint, I take the paint back. Wherever I got my oil changed, they'll do the environmentally safe disposal of the oil at the oil change place. I don't do it like I used to when I grew up, put it in a bag and put it in the garbage. We used to change our own oil and do that.
Maybe you could talk for a second about what are the barriers to getting the farm. That's where when we started out thinking, okay, how could we help? We thought after Jamie, persuaded us there was a safe disposal was one of the areas we could help with, that we thought, well, if we can help pharmacies get those boxes and, put in, and then, ran into the issue of having to be from the top down in all the chains, and all that applies to most of the places that are really convenient, like the grocery stores and chain pharmacies that have long hours. They don't have the ability to make their own decisions on this. So if you could to speak to that issue a little bit, because even here in Boulder, there really isn't any place that if you work long hours that you can take this stuff,
Except for Boulder
Right.
Community Hospital, they opened the 24-hour
Right.
one. And then I do think we did, I do remember that, because I was realizing it was almost a year ago, Gary, I think, that we first started talking about this.
Yeah.
And we had started initially with, you guys were interested in starting with trying to get it in the chain pharmacies. And we did a lot of work on that side, talking to Greg too, and finding that was not going to be really the best avenue. And then we looked into some of the doTERRA and some of the ones where you can use it at your home, or the mail back ones. And I shared some examples of that too as another option. And then the third one we did is we did the Take Back event at the Boulder Rotary, where we brought Boulder police there. And I think, I was just looking at that post I made. It was a long time ago, but where we got 5,000 pills back. So I just want to give you that context, Rob, too, to know that
Mm-hmm.
I think Gary's not really, he's being modest about all the work that Boulder Rotary has done so far and knowledge on this topic.
No, that's a lot. And I think there's many things that can still be done. I think we have to put bottom up pressure on chains. You know, they tend to respond to consumer demand, if not today. If they get enough requests for things, they do hear that, and that does bubble up, and they start to make changes. They sometimes claim there's not a lot of demand, and I counter with there can't be a lot of demand for something that's not even there, that people don't know about, that could be there. So it's a little bit of a chicken and egg with them. But there is some barrier towards cost, and the state has funding for putting drop boxes in locations that may be underserved, that don't have a box. And if there's a couple of them, 2 or 3 or whatever in Boulder in different places, the state funding would probably try to roll out to somewhere else that doesn't have someone. That's kind of Greg's job at CDPHE, is to try to distribute these across the state in the most equitable way possible. So there's not 2 of them across the street from each other in one city and not another one for 4 counties over.
So Rob, we have one of the places that we thought about they could go and be very useful is in these long-term care facilities, especially the larger ones where people are dying all the time and they're asking the family members to take the medications and stuff because they don't have a good method. We have one here, and you may be familiar with it, called Fraser Meadows. And they were the residents there, and some of them are Rotarians that live there, were very interested in trying to get a box there so they could do this, and they've been looking into it, and I haven't touched base back with them yet. But there was one of the people the residents that's relatively new to Boulder. She was a city council person in a Chicago suburb, and she said in her little township, they had disposal boxes at all the fire stations, which we started thinking about it, and it seemed like what a great idea. They're open 24/7, and they're monitored and have personnel who are used to dealing with opioids every day. And wondered if you've heard about that, or if you thought about that, and if not, what you think about it.
Yeah, it's a difficult thing. I'm not aware if there's anything that Illinois may have done to allow fire stations to do that. Federal law, the DEA, requires that take back be done by either law enforcement or pharmacies. And there's a process for registering as what's called a reverse distributor, or somebody that can take those medications back, because all of the drug distribution channels in the United States are regulated from manufacturer to ultimate consumer in that one direction, but they're not regulated coming back. In fact, until a few years ago, 2015, it was prohibited by federal law for pharmacies to take stuff back because of concerns over who knows what has been done with that. So the door was closed. This is a one-way door going out from a pharmacy. Now that's been changed, and pharmacies are allowed to be reverse distributors. Law enforcement are allowed. Long-term care facilities are not allowed to be a reverse distributor. And I think it's a difficult situation because where a lot of medications are, like you say, and we're getting similar questions from whether it's long-term care facilities or coroners. If somebody passes away, they were at a nursing home. Now there's a gigantic, bag full of medications. What do you do? Sometimes it's, do you give it to the family? But maybe the person may not have a family member that's there. What do you do with all these medications to dispose of them safely and properly and not have them diverted? And we're having a lot of conversations with our legislators about what to do, and if we can figure out how to manage this. And it's a vexing problem for sure, and we have not solved that yet.
Okay, so the prohibition that you think the firehouses and is all at the federal level, not at state level?
Correct. Yeah, the DEA says the only places that can take these are law enforcement, so registered law enforcement departments, and pharmacies. And they have to fill out a registration process with the DEA to be a registered reverse distributor. And the only ones they are allowable under law, federal law, is pharmacies and law enforcement. So a police station, yes. Sheriff's department, yes. Pharmacy, yes. Clinic, no. Unless the clinic has a pharmacy in it. that's a prescription drug outlet licensed by the state, and then they register as a reverse distributor, then that pharmacy, that clinic, if they have a pharmacy, that pharmacy could do it.
Okay,
so it's a limitation that, you know, the only ones that can do it.
Well, is that in, does the DEA have regulatory thing over non-controlled pharmaceuticals, or just controlled substances?
Just controlled substances. So,
Okay.
you know, some of the take back, we used to have a statewide take back program that applied just to household medications that said, you know, on the boxes, not for controlled substances, you know, not accepted here, and people would still put them in there. But the explicit instructions were these collection sites are not for controlled substances. It was only for everything else, and then the states can do that on their own. They can regulate those however the states feel. But once controlled substances are involved, DEA is involved, and not that they would go after states. I don't know. I find it unlikely that they would go after anyone, but still, it is prohibited by federal law that anyone other than law enforcement or a pharmacy return that stuff.
Okay, so, but for all the other meds, they could go back to any of these places. You know, would that be your understanding?
Well, theoretically, but again, the state may have statute. Each state would have its own statute about what's done with disposal of household waste, and that's in Colorado. You know, the CDPHE has regulations about household medication take back, and that's household meds, meaning everything but controlled substances. So they've got their own regulations, and that had been contemplated prior. And I'm not sure if that extends anywhere other than pharmacies or law enforcement, or if Greg, you know, is still, you know, managing that program distinctly, or if everything has been rolled over into this new program that includes controlled substances and non-controlled, you know, to streamline everything and basically have one program. Because otherwise it gets pretty confusing, as you can imagine. I can take my controlled substances here. I can't take controlled substances there. I have to take controlled substances over there, but I can't bring the other stuff. You know, so it's just good. I think the push is to try to have a unified system, so that no matter what medication you have, you take it back to one place, and we try to ramp up as many police departments, sheriff's departments, and pharmacies as we can to have those locations in every community, because virtually every community has a police department and a pharmacy.
Well, I'm wondering.
And in Boulder, actually, there's 13 locations right now. I was just checking on the website. There's been about one or two that opened up in the last year, but there's 13, including the law enforcement, the pharmacies, and also hazardous materials waste.
Yeah.
So that includes those with the CDPHE program and also private. I would be interested too, Rob, if you knew any more about the hospice at the federal level. I had heard that there might have been some legislation that was looking at how hospice managed medications. I don't know if you had heard any updates on that.
Yeah, I haven't. I know it's being discussed, and we're talking about it here too, whether it's hospice or nursing homes or whatever, to be able to try to figure out how to deal with that, because the quantities of medications are obviously higher. They just are linearly. As the older we get, the more likely we are on more and more medications, just as we age. And then, you know, then those locations, you know, just the multiplicity of medications. But right now, it's still, to my knowledge, that federal laws aren't changed yet. But
so, Rob, it seems like, you know, the household medication take back is legitimately a real environmental question that needs, you know, definitive research as to what. I'm sorry. Which, let me just get this. I apologize. I can't get that to stop until it picks up. It'll stop in a second, hopefully. You know, it struck me when I looked at that FDA website that I think I sent you the link for, that the only medications it was recommending be flushed were the controlled substances, and given the lethality of having those in your medicine cabinet, and the likelihood of anybody getting those out of their medicine cabinets without some really convenient way to do it, that I think maybe their judgment was that we'll save a lot more lives, short term at least, by getting them out of circulation ASAP. And so I'm wondering if you think that that's why those are the only ones that they seem to have on their flush list.
No, that's exactly right. And I've spoken with them many times, and that's been their viewpoint and their argument for a while. I just think a lot of others, whether it's SAMHSA, DEA, EPA, virtually all law enforcement, people in the treatment community, physicians, most folks that are involved in other ways, they're kind of the lone voice, FDA kind of viewing it that way. Most of the other, both federal agencies and folks that are in everything from prevention to treatment communities, believe that our job is to, and we have done enough of a job getting there to have, if there's 13 locations in Boulder, the argument now is it's easy enough to get something there because there's probably one just a few blocks from you. And so therefore, we're lowering those barriers, get that into the safe disposal route. And then that's also for us having the beginnings of long-term behavior change, which we're trying to institute, which is all medications, when you're done with them, take them back. Don't flush them. When you're done with them, take them back.
Yeah,
that's our goal.
I do have to look at the list again in Boulder County, but as of a couple of months ago, there was no convenient place for me to take them back, either in terms of time or in distance, other than the hospital. So in any case, and I know that's much worse in many places. So, and I think I'd love to keep pushing on that front, in terms of the direction we want to go. But I'm wondering if in the short term, if the goal is to save lives and prevent diversion, we don't need to consider, if you can't find a place, then flush it, as part of the message.
And we've debated this one for better part of 2 years at the beginning of our work. We really did. There was a lot of robust discussion and debate, and we came to the decision as an organization for what we do as far as the messaging is that we've decided our messaging will be, dispose of this, be it safe disposal, and that's what we're pushing, is to try to send that message. It's the most desirable message. If somebody is absolutely unable to get there, it's pretty rare that someone's absolutely unable to get to one of these, even in rural counties now with boxes, virtually in 63 of the 64 counties, that it's not possible for someone to get to one of these. It used to be, 2 or 3 years ago, it was impossible. In many counties, you drive 4 hours, couldn't get to one. Now, every county has a box. Many places like Boulder have more than a dozen boxes. There's 30 or 40 or 50 in Denver, and there's places I can drive down the street and be at one in less than a mile from my house and drop it off. And that's just the direction we decided to go, rather than send conflicting messaging. It's going to be hard for people to adopt behavior change and think that if it's just okay to flush, I'm just going to keep flushing. And at some point, we're trying to be strong with the messaging that isn't the preferred thing. Preferred thing is to take them back.
Right.
And just, we believe that's the best way to send that message, rather than kind of sound like we're hedging.
Yeah, I see. Well, they're hopefully, pushing as we're trying to change the provider behavior for, prescribing behavior and oversight, that the problem of having 30 or 40% of medicine cabinets having substantial quantities of opioids, that will change because of that kind of initiative, and so it won't be so much of an issue of how they end up disposing of it. But anyway, I guess yep. There's a question is I think we should continue to get I'd like to see what's if there's anything we can do to help on changing the rules or the laws to make it possible for disposal sites to be in places like the firehouse and so on. That woman was going to track down get some pictures for us and track down what their process was to get to that point. So I will.
Yeah, that would be helpful and would be great to know. And if we need, if that's something that people want to lobby for, then obviously in your district, Joe Neguse understands this stuff pretty well.
Right.
Was the head of DORA and was, personal friend in doing some of this work when the consortium was getting up and running. And so I know Joe extremely well and is versed in this. So is Senator Bennett, so is Congressman DeGette. I meet with them twice a year when I go back to Washington to meet with all of our delegation that are willing to meet and talk about these issues and what we're trying to accomplish.
Right.
And that is on the front burner now is what do we do with a lot of this, either in hospice or long-term care of any kind, to try to figure out, how to improve disposal options in those settings.
And, the idea of having it be only law enforcement, for example, being able to handle it when all licensed health professionals are handling it every day, so, and on the reverse thing, to only restrict it to, to law enforcement, that seems on the face of, especially in our current crisis situation, something that needs changing.
Yes, it's true, and it's a tough one. You tell people, whether it's pharmacies or clinics or long-term care, you can do this. That's wonderful, but the uptake hurdle is now I've got to pay for this unless the state comes along with funding or the feds come along with funding to pay for that. I've got to watch that box. I got to call somebody, or I got to pay for that destruction. We don't have infinite supply for numbers of boxes from state funding. We have a certain number. I have a budget for it that we can do state-funded boxes. Otherwise, some pharmacies are paying for that on their own, but then they have to contract with a vendor who's able to do DEA, EPA, DOT certified destruction. You have to have 3 federal certificates to be able to do that destruction. And we have a vendor at the state level to do that for the state program. But it took 2 years to get that in place to meet those kinds of requirements. So there's just, it's a complex, unfortunately, often burdensome thing with regulatory issues at all those levels to get something off the ground that sounds very easy, like you're right. Oh, that's a logical place to target to go to long-term care facilities or clinics or whatever that's a little different. But it's just the hurdles start to pop up, the costs start to pop up, and then people tend to revert to, okay, let's go with pharmacies and law enforcement and just ramp those up.
And Pete Palmer from this long-term care facility that Gary mentioned he's a Rotarian. He's very interested in kind of having a collection point there that then could be taken to a legitimate place.
Right. It's just anything that's a box that isn't in somebody's possession, is supposed to be in the direct control of a pharmacy or a law enforcement agent if it's not in a person's possession. So that's, if you put it in a box, at the long-term care facility, it's no longer in the possession of the resident, nor is it law enforcement, nor is it pharmacy.
See, when we did our one collection, we did it at a Rotary Club, we had the police come to where we meet.
Exactly, because then it's in their possession. And that's why we say, hey, if you do one of these take-back events, you have to have a policeman there, or it has to be at the pharmacy. So a pharmacist, like a roving pharmacist, that's not a pharmacy. That's it's a clinician. But a roving policeman, that's a law enforcement agency, and it's just a slight different wrinkle in the way things are defined as what is a law enforcement versus a pharmacy is a physical location. Law enforcement extends to wherever the policeman is.
And Pete and I,
so now it's in their custody, and they can take custody.
That
right, and I think you guys saw that all because we pulled some strings to get the Boulder County Sheriff to come.
Jamie, excuse me, but you and Merrill are both talking. Merrill, your microphone is not working very well, so we can't really hear you.
I'm gonna switch to headphones.
Okay.
The one thing I want to say was that Pete Palmer was thinking in the lobby of the facility that could come, they could collect the medication. The residents wouldn't have to travel that way. They could just come down to the lobby, drop off their meds, and be done with it.
Yep. And building those partnerships would be wonderful. We've done that with the Arapahoe County Sheriff and 2 or 3 different senior living communities like Heritage, Eagle Bend, and those in that same area. And this was Sheriff Walsher at the time that was doing this, where we would have same thing, come in, whether it's an event or, hey, first Tuesday of the month, we're showing up at 10 o'clock on the first Tuesday, bring your stuff. And, he would collect it all, drive it back to the Arapahoe County Sheriff's Department, put it into the locked storage where they have custody of it, and it's all legal. Then he would fold that into the return that they're doing. So there are ways to bridge that, and that may be something to explore, is how could Boulder County, whether it's PD or sheriff, how could they potentially partner with long-term care facilities to do either an event or a periodic collection first Tuesday kind of thing to accomplish the same thing for people. And they come to them, pick it up, take it back into custody, and I wouldn't say problem solved, but somewhat problem reduced.
Can a pharmacist
Yeah,
do
we
that?
did try to get sorry if I'm talking over, but we did try to get, we did have pulled some strings to get the Boulder County Sheriff to come to that Rotary event, but they did have to pay the person overtime to do it. And so there was some concerns just about the cost for the sheriff's office. And they said, that's not something that they could do long-term. We did propose doing it at the long-term care facilities or on other events. And we reached out to some other police departments as well. Maybe Longmont would be more open to it. But, they were very accommodating by coming to the Boulder Rotary event, which was great, but it didn't seem like a good long-term solution for them. Having said that, I do think CU Boulder is having an event in March, mid-March, if you guys wanted to partner with them on their campus.
Okay. Rob, did you say the pharmacists can't do that? They can't operate outside of the pharmacy? It's only law enforcement?
Right. It's law enforcement is the current interpretation that I've heard from both DEA and from pharmacy attorney type people is that the view is that if it's not in the pharmacy, that the pharmacist can't take custody of that stuff if it isn't at the prescription drug outlet. So if they're not at a pharmacy, but a cop can, because they can take possession of something, even if they're out in the field, the cop can take possession, make an arrest in the field. They can do their work in a field where a pharmacist can only do their work at a pharmacy as far as the product. Okay. So it's a wrinkle, but it's one where we believe the partnering, it appears to be the partnering has to be with a law enforcement agent to do an event that isn't at the site of a police department or a pharmacy.
And is there a definition of a law enforcement agent? That because there are like sheriff deputies that are part-time that aren't real highly paid that could be doing this, or people who are retired or semi-retired. Is there a strict definition of a law enforcement agent that keeps us from being creative in terms of making this partnership work from a budgetary standpoint?
I think it would have to be an employee or agent of somebody of somebody who has registered as a reverse distributor. So the law enforcement department or agency would have to register with DEA. Then it's whoever can act as an employee or agent of whoever the head of that agency is. If they deputize somebody and say you're an unpaid deputy, here you go. You're deputized. You can undertake these functions. That's a function of local law enforcement to define what do they do and what do they allow certain people to do or not. But then the responsibility, obviously, for that rolls to the chief law enforcement official of that agency, and the agency registers as the reverse distributor. So there might be ways, like you say, to use part-time deputies or somebody who's retired, as long as they have some formal relationship with that department who has registered as a reverse distributor. There may be some ways to get creative to do that.
Okay.
I think that's a really good point, Gary. And I think the other thing with that is how much has the police department looked into this as something that they tend to do. For example, they provide security at marches and so on, and they look at it as what they do. But I'm not sure how much the opioid crisis, how much they've considered that. Like, for example,
Rob's point about the medicine cabinets, do they know the seriousness of the issue? And if they do, is it coming from the top? So they've considered it as something they want to accomplish, or is it just someone coming to them and saying, well, this might be a good idea?
I think it really depends on what level you broach this at, and I think it has to come top down.
Exactly.
Yeah. And we've had and it has been very variable across sheriffs and police chiefs as to what they've thought is important. We do work with the police, the Colorado Association of Chiefs of Police and the Sheriff's Association to try to put this kind of programming in front of them. The Municipal League, the County Commissioners Incorporated, all these folks to try to say, whether you're a commissioner, a municipal leader like a mayor, a police chief, a sheriff, whomever you might be at that level, these are key strategies. And one of them is always that we put in front of them is safe disposal as one of the key strategies. Naloxone, safe disposal, public awareness, provider education, ramping up access to treatment, limiting opioids, the same kind of small set of things that we promote to all of them. And then some do. They jump in. Dave Walsher at Arapahoe County, he just jumped in and said, I'm going to put the disposal box right by my desk. It's top down. We're doing it. We're going to drive out to places. I'm going to collect it myself and put it in my trunk. And he didn't charge them for that. And he did it once a month. He went to Heritage Eagle Bend once a month by himself, the sheriff of Arapahoe County, the head guy, and picked up the meds himself, put them in his trunk, and drove them back.
These are great stories.
Because he made it a priority.
These are great stories, yep. Rob, and I think they set the stage for help of getting cooperation. The other thing that could help a lot is if they had community partners like Rotary that could run, set up all the logistics for them and so on, that makes it a lot more doable and when they start thinking of budget and other time constraints, that the idea of partnering, I think, is a really good one.
That's a great one. Dave did it. That's exactly what he did with Southeast Rotary and South Denver Centennial. So Centennial Rotary and Southeast both partnered with Dave. He was the one that suggested, why don't you speak to the Rotary, my Rotary, the one in Southeast Denver, why don't you do that? And here, I'm going to come and I'm going to do this. And just, it happen to luck out that he happens to be the sheriff of Arapahoe County. So that's, he's able to be a mover and a shaker at a whole different level because he's the guy on the inside that we want to get to.
Is he a Rotarian?
Yes.
Aha. Okay, well, that would be a great contact to make. Would you mind sending me his contact info? Because that.
Sure. Yes, I'll dig that up.
Just to let you know, we're our behavioral wellness committee is working on the start time things at the high school, and one of the things we're doing is getting the Cherry Creek people who have made the change start times and are studying it to work with us and get their superintendent to talk to our superintendent. So this could be an analog of that kind of activity that we've actually gotten requests from Cherry Creek Rotary Club to come up and see what we're doing, so they could possibly do the same thing. So I think this is
wonderful.
Yeah. So
yeah, terrific.
Yeah. So I think you've given us some good ideas for strategies, and we're going to hopefully be able to keep working with you on the things that can, be the big levers in terms of changing, what's allowable and what's not. And we'll find out about that fire station project up in the Chicago suburb and let you know what they did, and hopefully that's legal. But
right, and if it is something that's replicable, we would be all over it. If we thought that I just hadn't heard that one before. That if that's replicable, and it's either they count them under same guise as law enforcement, or if they did something I'm not sure what they would have done, but if that thing has legs, then we would of course want to include our fire department colleagues in this work and make that another place.
Maybe I'm wondering whether the sheriff's department could deputize and we could train all the fire department people with some kind of take back training, so that everybody's comfortable that they're to the extent that they have to do anything,
right.
That
to allow them to do that. It's a good question. I'm eager to learn more about that and see what, what they're doing and how they're doing it.
Okay, we'll be back to you on that. So I think
Terrific.
we've come up with some good strategies now, and for the time being, we can continue to use our that little flyer we were distributing in pharmacies. Maybe try to extend that. And one question on that I wanted to ask you, based on what came out in the news the other day about Google having trying to be a center for up-to-date disposal sites. Are you part of that?
We're not directly part of that. That's something Google's doing on their own with some other partners. We weren't involved in that one, but we don't have any problem with, here's ways to look for sites that are close to us. And if we think there gets to be a point where our list in Colorado, because our interest is to try to maintain the best possible list for the state of Colorado and help the CDPHE do that and then promote it and try to, get that list being used. But if there's a better mousetrap, we want to be aware of it and either refer to it, link to it, incorporate it, figure out what needs to be done to look at that and be aware of it.
Well, that's why I'm asking the question. I mean, are they validating their? I mean, is their list syncing up with yours, or where are they getting their list from?
I have no idea how. I don't know how they're building their list. I know they were partnering with some organizations to try to do that were helping promote some different kinds of take back strategies. But it was not with a state level partner like us here in Colorado. So there's just independent work going on in this coming from different places. Ours was entirely state generated. We tried to have that coordinated through CDPHE. We partner with them and link to that site so we have a single place where we're maintaining what our list is for the state funded program. But there are places that could be participating and doing this that aren't in the state funded program that could be not listed. So there is this issue where as this grows, it may be desirable to either have us tap into that and draw in those places, contact them, serve them ours as additions to the list. It'll be a what do you do when there's two different lists kind of question, and that may be aware of both, merge one into the other, what have you, as we see what happens with it. It's pretty early in that. Not a lot of people have seen that yet, and we're aware of it, but have not made a decision on, well, here's how we need to act on it.
Okay. Well, Google has a presence up here, and I don't know how they might or might not be related to that project. But if you're wanting somebody else to try to initiate a contact and connect you guys, I'm happy to try to do that.
Yeah, I'll let you know. Our safe disposal work group is one that sort of monitors things happening with all sort of things safe disposal related.
Right.
And if they express that, I have a pretty good understanding of everything that they're doing. They have 100% idea of what they're doing because we have so many different work groups in so many different areas that I usually defer to the chairs of the work groups for the very best information.
And is that Greg?
Yep, that's Greg. And then we have a faculty member, a geriatrician faculty member, Sunny Lineber from the pharmacy school. So she's very acutely aware of things like the nursing home care, long-term care, that kind of thing, and this very issue. And that's why we have her there to try to help address these issues about what do we do in the environments where the medications are most present, which is, again, just simply as we age, we have more of them.
Well, the reason I brought it up is that I had assumed that they were getting their list from you or your organization, your work group, and that we should put their website or link on our handout. But since they're not, I guess we would like clarification on whether that's a good thing to do or not. So
that's a very good question. Jamie, do you mind taking that to the safe disposal work group at the next meeting?
Sure, I'd be happy to.
And bring that back. That's a perfect kind of question to route to them and see what their opinions are. And they would probably weigh in as far as our statewide effort as to what do we think of that today. And what's our recommendation for that kind of thing today? And it may be go ahead and list both. Here's a starting point. And if you don't find something here, go here. It might be, don't list that yet because we don't know what that's, we haven't vetted those. But we'll let those folks weigh in and get you an answer.
Okay, perfect. And just a question for you is, the district attorney is of Boulder County is in our club, and he's actually going to be our speaker next week. And I can actually bring up this issue with him if that's and he could possibly take lead with the law enforcement chiefs if we want to get their cooperation, talk about, or uh, providing personnel for some a new way of doing it, that kind of thing, and let you know what he says if you think that's a productive route. Or the sheriff also is also a good friend of the club. He's been there a couple of times. He's not a member, but as that's true of the chief of police too. So we could go either direction. I was wondering if you had a thought about whether both a district attorney would be a good avenue, or.
I certainly think it doesn't hurt to raise these. Hey, here's issues we're seeing. We'd like to see more availability of places to do this because we understand this is a problem and this is a good strategy. And our interest at Rotary is to help accelerate that. And we'd like to have conversations with you, as whether it's the chief or the sheriff or the DA, how do we try to accelerate this process and figure out, especially some of these difficult situations like nursing homes or long-term care facilities or hospice and where.
Okay. Well, and the last thing I had on my agenda, and then we're open to anything you want to talk about more, is, we've had members in our committee that we're interested in and that are available to go to the medical society and the dental society, for example, and see if we can leverage some kind of a effort to get these handouts that we've created with the disposal sites on the back to be distributed through their clinics and offices, and wondering what you thought about that. In other words, medical and dental offices as places for distribution of these.
Right, and I think any of that is a good idea. We do very much the same thing. We've engaged with the Colorado Medical Society, with emergency physicians, with Surge One that operates 30 ambulatory surgery centers. Virtually all the hospitals now have something that they're doing as far as messaging and getting stuff out to patients. Some of it's from ours, some of it's not. We don't so much care, who creates it.
Right.
We provide materials to people that want them. We will co-brand them with their clinic logo and just give them to them, and give them to whether it's pharmacies or a single pharmacy, all up to we gave up stuff out to in all of the Kaiser Permanente clinics across Colorado a couple of years ago. We gave them 40,000 units of those to give out. So we want to do the same thing, help make it possible for them to have these materials. We have a resources page on our website that clinics can go to and just order materials, and there they are, and you can have them.
Well,
and ours is trying to continue to promote that.
Well, that's what we were kind of hoping for, is that your offices would be able to provide the actual materials, and we thought that might be the case on our pilot, but then Jamie left the county and we didn't have that. We had to come up with some emergency funds to get our pilot going. And I know Jamie has identified some printing resources in the short term, but if we could, we'd be happy to, contribute our design, which I think people like, if we could get the commitment for, printing and distribution from your offices that are doing that already, so that we could know that once we get people to want to do it, that we have a way for them to do it and follow through without having to try to fund it every time.
Right, and I'm not sure that we would fund, as folks have done some local adaptations of some of our resources and our durable materials, our collateral, and have done some local adaptations of those. And we've sometimes helped with some initial print runs and that kind of thing. It's what we try to offer anyone is that, we have the statewide collateral that we've built that can be co-branded, and then we can produce as much of that as people want. it keeps us for us, a more controlled way to control and keep messaging consistent, and to provide, here's an easy way to, rather than we've got 27 different disposal brochures going around the state, we want to try to streamline those. But that's not saying that locally you can't do something different. Absolutely you can. We just don't want to take on the sort of open the door of this could turn into, 50 or 60 different versions of each kind of piece of collateral we have when we try to localize them and then make them available through our sort of ordering process and shipping and all of that. So it's a kind of a tough one, because we want to be supportive and provide that. But for us, if we fling that door open to, hey, anything anybody produces, we will pay for printing. We don't have budget for that kind of a sort of a door open approach where it's just sort of an open invitation to produce whatever you want. We'll print whatever you want, because that's for us uncontrollable budget.
Of course. But what I'm saying is that Jamie has suggested, please chime in, Jamie, that several other groups have asked about, they like the format we've got, and it needed to be something that could be distributed at the pharmacy, put in a bag or stapled onto it. And we just came up with a pilot idea, and it seems to be something that other people like. We'd love to put it in your distribution channel for other people to use along with us, but but there wasn't a collateral material that would function the way we needed it to, and so we did that ourselves. But I'm wondering if there is a pathway to incorporating this into what you're already doing, so that there is a distribution. There is an appropriate material, collateral material to hand out in doctors' offices and pharmacies and so on that will do the job. And we don't.
Yeah, and we can take that. And what we typically do is take those, ideas like that, run them through our groups, whether it's a safe disposal thing or a public awareness thing, and maybe one or the other of the groups that sort of oversee our messaging and make sure at least it's consistent with that. And then, is this something that we want to do, and basically put our name on, if not on the material itself, put our name on in terms of sanctioning, hey, we're going to go ahead and say, that's good messaging. We're going to help start providing that as a resource. So we just typically run that through our groups, and Jamie could do the same thing with that and say, hey, here's a safe disposal leaflet, the bag sheet. And we have a rack card kind of format that's a little bit like that. It's just in a harder cardstock version of something like that about safe disposal. But if that's something the group thinks, hey, then do that, then we just sort of route those through our work groups. And if they want to do it, then we put it into our channel.
Jamie?
Yeah, we Greg and Michael Davidson, and they were supportive of it. And then Whit said that there was a little bit of OBH funds for printing, very small, just overflow funds, but for printing for local efforts. But we can talk about this later in terms of what kind of your vision is, Rob. But Whit did say that there's a small amount just to try out what it's like to pilot one of these flyers.
Right. And we've talked about having some amount of support for local, materials, whether it's, public awareness in general, or everything from a billboard or a poster to a rack card or whatever it might be for someone that wants collateral for public awareness in general. And we've talked about having some amount, some small amount of our budget set aside for that. So for this kind of thing, like, hey, in Boulder, we want to run, 20,000 of these and try to get these into clinics throughout Boulder, and then make that available if others want to have it.
Yeah,
maybe less than 20,000 for the budget, but
yeah,
approved. But we could see.
Yeah, what we would be thrilled that if there was a piece of collateral that would have done exactly, met that need, and for the pharmacists, we went around and asked them. And when I talked to Michael, apparently there wasn't a lot of success in getting pharmacies to uptake it, and it may have had something to do with the format. I can't really say, but we're willing to contribute, our energies to making it something that other people can use. And as I've been suggesting to Jamie, if they're in a community with a Rotary Club, we'll use our things and see if we can get the club to partner so that it's, not just a state, a local governmental organization, but they get support for and volunteers, et cetera, to help them. So,
yeah, I think that'd be a really good strategy for us. Would be one of the most valuable things you could do would be to continue to engage other Rotaries, laterally like that to, get more support, more of them activated, wanting to join into that kind of effort and doing whatever it is they can in their local community. And
right.
that's probably the single biggest benefit that we could see immediately would be, boy, you can activate an awful lot of people to be aware and then engaged and starting to do something. And that would be a huge, activation of that network.
So Jamie, I'm going to suggest, we have a district meeting coming up. Merrill, do you know when that date is? You're muted, I think. Yeah, if that's coming up, and if you guys could,
I don't know.
we could have this flyer and you guys will print it, so that people could use it and distribute it and partner with anybody that Jamie identifies or other people from your side that we could have suggest that there might be a booth or a table at the district conference.
Yeah,
that
it's a great idea, Gary.
Would leverage
63 Rotary clubs, and they usually send representatives to this district conference, and they have a tabling exhibition, as you know, and we could have a table there.
Yeah, I think it's a great idea to, like Rob was saying, doing it laterally, like when we were doing it at that, Metro or the mental health event and sharing with other Rotaries. Because when I go to Rotaries, they want to do something. People want to get involved, and it seems like a good fit because there are folks that have opioids in their medicine cabinet. So, that medicine cabinet problem, it's an appropriate message to share with Rotaries. So I think, the route you guys are on with sharing, spreading this Take Meds Back message, if it's with your own flyer where you can put the Rotary logo on it, it's great, just to co-promote with Rotary because people recognize Rotary. And, if the local coalitions connect with Rotaries too, that's a win-win. So I really love that direction in terms of sharing the message that way, because Rotary does have so much recognition. It is all over Colorado.
So Jamie, if you could take back to the group, the flyer we've got and see if they want to use that as a co-branded alternative piece of collateral or something that, will do that job. And we can, and see if they're interested in, having a table at our conference, our district conference. I think it's in May, is that right?
It's in April 27th. I just looked it up.
Then, we could kick off that with us, who knows, maybe a dozen clubs or something.
Yeah, wonderful idea, Gary.
Rob, and I'm wondering whether you might want to put together, you may already have this, a video, a 20 to 25-minute video that could be used at the smaller clubs. There's a lot of smaller clubs that meet for breakfast or something like that probably wouldn't, 10, 20, 30 people that, isn't going to have a lot of bang for the buck, but they might be really interested in this as a project. And if you could deliver the message like you're already doing without having to travel, maybe just be on the tail end of the call for Q&A, we could help make, advertise that as a way clubs can jump into this and get everybody engaged.
And we're happy to. We've talked about recording some things, but for the time being, we've been able to manage the volume of requests we're getting because we're hiring people like Jamie to help multiply the ability to attend more of them and participate with more of them. We now have 3 and soon will be 4 people across different parts of Colorado, in addition to myself, in addition to a couple of other people internally. So we've probably got 6 or 7 people who are able to, engage and do a lot of these talks. So it's, something that we think we can, for the time being anyway, meet the demand if there are from even smaller rotaries.
That's great.
Yeah, and if there's any thoughts, Gary, about improvements to the talk that you'd like, I know I gave the ones for the Boulder Rotary and then the mental health one, and then I did another Boulder Rotary, and I've got a couple more Rotaries. But if you have recommendations about how you'd like the talk to be improved or content, the content's pretty similar to what Rob has in his slides, but of course we can't ever match his knowledge and expertise on this subject, unfortunately. But if you have any feedback about how we can improve that, we will be hiring more external relations strategists. So it's helpful to get that.
Okay, great. Well, if you want to talk further, Jamie, about what the ask is at the next coalition meeting, in terms of co-branded flyer that could be distributed and by local Rotaries if you guys are willing to print and offer that the quantities needed, that's going to make a huge difference in terms of the barriers to having to pick up that project like that, I think. And
yeah, and I think what we had allocated for printing was very minimal so far, just to try. It was some overflow money for a short period of time that, they asked, what do we need help with? And the first thing that came to my mind was you guys, because of all the hard work you've been doing on this. But before we offer it as like a long-term sustainable solution, we should probably think through some more of the details.
Okay, so that and if you do have a solution to that, the table at the Rotary Conference would be two good things.
Yeah, we'd be happy to do that.
Okay.
And as a Rotary ambassadorial scholar, I just like the opportunity to connect with Rotarians too. So it's always a nice fit that way.
Okay, great. Okay, so Rob, do you have any other ideas or questions for us?
No, I don't think so. It's been really, really good conversation. I appreciate it.
Appreciate it as well. And then if not, then I guess we say goodbye for now, and hopefully we'll have a follow-up meeting after we get some more information for you and on novel strategies that we're going to try to see if we can work on here.
Sounds great. Looking forward to it.
Thanks, Jamie and Errol.
Thanks, everyone.
Gary?
Yeah.
Gary, I have a question.
Thanks, everybody.
Okay.
Before you hang up, Gary, I have a question.
Okay.
Who's the chair of our speakers committee now?
Of the program committee?
Program committee, right?
Carl Kurt. Yeah.
Kurt?
Mm-hmm.
Great. Thanks a lot.
Okay. Okay. Talk to you later.
Bye-bye.